Gentlemen, we back again to our webinars with Dr. Mehmet Tonge, again with MEDIPOL Mega University Hospital representative and doctors. We're going to present and share with us his experience and knowledge in application of gamma knife radiosurgery in neurosurgical practice. Dr. Mehmet, floor is yours. Please go ahead. And after your presentation, we might have from audience several questions. We need to answer those questions who is coming from other doctors and colleagues from CIS market. Please go ahead.
Okay, can everybody hear me?
Yes, we do.
Okay, good afternoon to all from Istanbul MEDIPOL University Hospital. My speech today will be on the applications of gamma knife radiosurgery in our neurosurgical practice. Okay, first of all, I'd like to make clear some terms. As in previous speeches, I heard that they mentioned also, but I'll again clear it. The stereotactic radiosurgery term means the three-dimensional tailored radiosurgical approach, which is in detail described in ASTRO's guidelines and typically performed in one session, sometimes up to 3 to 5 sessions, and high dose radiation to a very precise target. There is some nomenclature about this. While we mentioned the fraction stereotactic radiosurgery, it means 2 to 5 fractions. If we are fractioning more than 5, but guiding with the stereotaxy, the radiation to the brain, we name it the fraction stereotactic radiotherapy. And you all know about the conventional radiotherapy, it's fractioned without stereotaxy. Well, why this is important? You know, to be able to reach the deep structures of the brain with a precise localization without harm to the brain tissue has always been a challenge among the neurosurgeons and all the physicians in time by history. It goes back to more than 100 years, the first attempts for this, the mathematical calculations, the topographical data, they're all together in some devices specifically tailored for able to reaching inside a certain target inside the brain. The neurosurgeons developed the Cartesian system to localize these structures, and then in time, in the last century, these attempts gained a lot of popularity and a great field of use in our neurosurgical practice. And after the discovery of the therapeutic effects of radiation in treatment of especially the tumors, they combined the radiation treatment with the stereotactic guidance to be able to send the rays to a certain target. A Swedish neurosurgeon, Lars Leksar, has first invented the modern type stereotactic frame, which is used in localizing the target. And then it developed to the radiation treatment and proton therapy. And finally, the gamma knife radiosurgery system was first invented by him in 1968, then became spread all over the world after 20 years. And now in all developed countries have this device to perform stereotactic radiosurgery for the brain. It's the gold standard method now. There is a natural cobalt source inside the device which produces gamma rays, and it has evolved in time. So in radiation oncology, this fractionation you all know, that they have a calculation. There is different alpha beta ratios for different tissues and tumors. But in radiosurgery, we administer a very high dose of radiation. For that reason, these fractionation formulas are not applicable. and that is totally lethal radiation. So for that reason, because it also can be dangerous, this radiation must be very accurate and precise. In order to achieve this, we have the stereotactic radiosurgery modalities. It was mentioned before, the particle sharp particle, proton beam therapy, or neutrons, and there is the photon-based treatments. Gamma knife is one of them. And the proton beam, you all know that is a huge machine, very expensive, and there's a cyclotron, and it also produces some nuclear medicine sorry, okay, and I'll pass this fast, and these are the photon-based modalities. You see in here the X-rays are and gamma cosmic rays are in the electromagnetic spectrum. We use the gamma rays in gamma knife. And the X-rays are, there are very well-known devices for this technology, and the gamma knife is using the gamma ray. This is a LINAC device. It's an X-ray based stereotactic system. The ancestors of the modern era. And this is the recent versions of the LINAC system. It's the linear accelerator, the shortened form of this sentence. And this is a exemplary treatment planning. And the CyberKnife treatment is a mounted lightweight LINAC device on a robotic arm, which makes able to do the stereotactic radiosurgery. Was also developed by a neurosurgeon, John Adler, from Stanford University. The neurosurgeons had great contribution to radiation oncology field in history. And this is a CyberKnife device. This is planning station. And while we come back to gamma knife again, it's the gold standard among the radiosurgical methods because the dose distribution of the gamma knife, we call it the gradient. Dose gradient is very strict. That means you effectively can irradiate a target, and when you go just a very little among the target, you will have not much harmful radiation effect. This is what we call the gradient index, and this is the highest in gamma knife device because of its nature and structure. I'll give some examples to you about our patients and indications. The main indication for the gamma knife radiosurgery is the small tumors located mostly lower than 3 centimeters in diameter or 15 cc in volume for the supratentorials and 10 cc in volume for the infratentorials. And we mostly choose this treatment modality for the surgically challenging cases. If we predict that the surgery will be more riskful for the patient, then we better choose radiosurgical treatment. Or there can be the patients, they have been treated surgically before, and it can be recurrent or residual tumors. And then we again can prefer radiosurgical treatment for these patients also. And I will mention it in the forward that there are some other indications other than the tumors, not only the tumors for the gamma knife. It's another interesting point for the radiosurgical treatment. One of the most prominent indications of gamma knife radiosurgery is the vestibular schwannoma. As you see in the grading system, the 4th grades, for example, are not a candidate for the gamma knife radiosurgery. 3s are discussed, tailored for the individual patients. 1 and 2 is the best indications because of this size. The vestibular schwannomas are mostly presenting with the loss of hearing gradually, tinnitus and vertigo. And in the advanced cases, there can be the motor findings due to brainstem compression in here. And this is our treatment planning, an example from our patients. It's been well documented the effect of the radiosurgery, especially the gamma knife literature, is a huge literature in. We have more than 30 years of followed up patients in the literature. The results are very satisfying. More than 85% of the success rate in the treatment is achieved with the gamma knife in vestibular schwannomas. While we mentioned about the success of treatment in these benign tumors, we also involve the patients whose tumor size doesn't grow in time. We desire the tumor to shrink, but during the follow-up in years, if the tumor size is not changing, then we also consider this patient's successful treatment. This is an example of our patients. As you see in here, this is the gamma knife session image, and 3 months after the treatment, you see a black hole in the tumor. And this is the effect of the radiation, early effect, and maybe a little swelling around. This is what we expect in the early term. And this is another case. 6 months later, you see the black hole inside, tumor is shrinking. And this is 4th year after treatment. The size of the tumor has shrinked when you compare with the initial images, and it's not changing over years. Another patient, this is a grade 1 tumor, pure intracanalicular, and in the 5-year follow-up after gamma knife, the tumor size is not growing anymore. This is a successful treatment. And for the metastatic tumors, not only for the benign, we also perform it for the malignant lesions. The fast-growing lesions respond fast. And we mostly see complete disappearance in the metastatic tumors, fast-growing tumors. This is an example. You see the tumor in here. This is 3 months later, and 10th month, you cannot see the tumor. For the arteriovenous malformations, this is a challenging pathology for neurosurgeons. Maybe the most difficult surgeries are for this entity, and has also the risk for bleeding in lifetime. So thanks to this technology that we are now able to treat this pathology without harm to the brain. After the radiation, there are some pathological changes occur, and you see here the nidus of the AVM, and you can also see on the MRI. And after a while, meantime, 2-3 years, the AVM disappears in most of the cases. This is the 18 months after treatment, and this is 2 years after treatment. And you also see the angiography of the patient. The AVM is not visible anymore. And almost always it doesn't recur as compared to the endovascular embolization. This is another case. And 6 months after gamma knife, it just began to shrink. And 2 years after gamma knife, it's disappeared on the MRIs. And we check always with the conventional angiography, and we confirmed that it's completely gone. For the meningiomas, especially for the skull-based meningiomas, which is difficult to access surgically, we also perform radiosurgery. As you see in here, 2 years after gamma knife, the tumor has almost completely shrinked. And also it's applicable for the pituitary tumors or other paracellular region tumors, which are also eloquent area. Another interesting indication for the gamma knife is trigeminal neuralgia. It's very useful. There are huge series now within time. And we also have a series on trigeminal. You see, it's a very challenging pathology. We do perform a lot of other procedures, but not all the patients respond, or in the elder age, they are not candidates for the surgical treatment. So we can select the radiosurgery, and after meantime 2-3 months we achieve the painless situation. This is the data from our Lexal Gamma Knife Societies and International Stereotactic Radiosurgery Societies documents. All the patients, almost all the patients from all around the world are documented since 1968 in the society, and up to now there are more than a million patients have been treated with the Gamma Knife system in the world. Most indications are tumors, and when we look at the largest markets in the world, Turkey is the 7th largest market, because we started the Gamma Knife radiosurgery program as compared to the other countries very early. The first Gamma Knife device was deployed in Turkey in the 90s, and then my institution, my previous institution, in 2004, and then it spread to the country, to the other centers. And when we look at the indications among the benign lesions, the meningiomas, the vestibular schwannomas, pituitary, and there are numerous other tumor types, brain tumors, and also most of the malignant tumors are metastatic ones. We do not so much prefer for the glial tumors for the radiosurgery, and also the AVMs are the very good indication for the radiosurgery. And as I mentioned, other than the tumors with the AVMs, there are functional indications. Rarely we can perform for also psychiatric situations, obsessive compulsive disorder, and for selected patients for movement disorders like Parkinson's disease or tremor. And also the ocular pathologies, mostly for uveal melanoma. And as I mentioned, it's almost 40,000 patients accumulated in Turkey's database. And it's similar with the world's measures. While we look at the workflow of our radiosurgery, first, this is a daily basis treatment. Patient doesn't need to stay at the hospital at night. Patient comes in the morning, then we mount a stereotactic frame on the patient's head with screws under local anesthesia. It's not a painful procedure. Sometimes if the patient has claustrophobia or something like that, we can take assistance from anesthesiologists for sedation. And then we perform stereotactic imaging with MRI, CT scan, or angiography, or in some selected patients with PET scan. And also for the pediatric patients or debilitated patients, it's possible to perform this treatment under general anesthesia. And then we make the measurements, calculations, treatment planning, and then a patient goes inside the treatment. It depends, but takes between 20 minutes to a couple of hours sometimes. And then we remove the frame, and the patient rests around 1 hour, takes oral medications and food, then we can discharge. Our institution, our neuroradiosurgery institution, has 3 stereotactic radiosurgery modalities. We have Gamma Knife and Cyber Knife and TrueBeam system. But you all know that having devices is not always good for the patients. For a better decision making, you always need a strong backup with a teamwork, with a strong team. So our radiation oncologists, radiation physicists, our staff, and we have weekly neuro-oncology meetings with the contribution of many other departments of our university. And we decide for each patient individually for the treatment plan and the follow-up protocols. I'd like to introduce you, if I have a couple of minutes,
Go ahead, please.
Okay, my department. This is our neurosurgical department. Our chairman, Dr. Akalan, is the former training committee president of the EANS and treasurer of EANS, and the founder of the Hacettepe University's Pediatric Neurosurgery Department. Dr. Şekerci, he is the former Turkish Neurosurgical Society's president and executive committee member of the Turkey in WFNS, World Federation. Dr. Dinç is mostly in leading the spine surgery program, and also Dr. Zırh is specifically working on movement disorder surgery. This is me, mostly working on functional neurosurgery and radiosurgery. Dr. Tahta is mostly working on epilepsy surgery and neuro-oncologic surgery. And also Dr. Çetinkal is working mostly on peripheral neurosurgery and spine surgery. Our technical equipments, we do have intraoperative MRI, ultrasound, and CT, and also X-ray, 3D angiography, gamma knife and cyber knife, as I mentioned, the intraoperative neuromonitoring, the neuronavigation system, the stereotactic surgical system, the neuroendoscopy, and ultrasonic systems. This is our some part of our team, and I would like to thank you all for listening and to prepare this nice meeting. Thank you.
Dr. Mehmet, thank you very much for your comprehensive presentation regarding the new technologies, which you started very old versions of technique, how they were trying to do and how they arrived to this updated technology. It was very interesting for me as well, and so many colleagues are writing from different countries. It was very interesting and informative presentation for them as well. There is many oncolog and neurologist professor and doctors was listening to you. Still they are listening, and they made several comment and question actually in the platform, and I would like to ask you that if you can answer to them. They said that, do we have, as an institution of MEDIPOL, since you have in your institution TrueBeam and gamma knife and other technique and technologies as well, do we have a kind of rating, success rating, treating the patient in cyber knife or in gamma knife or in TrueBeam? What is the result? I mean, which one is the best, or how you are choosing the patient to be treated in which technique and which technology?
Well, thank you for the question. And to be honest, we are preparing a study on this also, and we will publish soon. But basically, we mostly select gamma knife radiosurgery for benign lesions, and sometimes for the malignant lesions if it is extremely located in the eloquent areas. For the cyber knife, we mostly prefer, if we desire to hypofractionate the treatment for the larger tumors or in some metastatic tumors, because you don't need to mount a frame on the patient's head. It's a thermoplastic mask, and the gamma knife, for that reason, we mostly prefer for single session treatment. And for TrueBeam, it's mostly it's doing full body like cyber knife, and it's doing the regular radiation treatments of the other parts of the body. And sometimes for the multiple metastasis, it is very fast treating device. We discuss in our weekly meetings together with the radiation oncologists and other colleagues. Then we decide. It's tailored for each individual patient on a patient basis.
The last questions again from the doctors. In case if they would like to come for a week or 2 weeks training in your departments, will you accept doctors from CIS market to share your know-how and knowledge and experience.
We already had the visitors from several countries for both for surgery and for radiosurgery. They're always very welcome. There are some restrictions due to the pandemic nowadays, but afterwards, so again, during the pandemics, we can have the visitors, but they're always very welcome. We can always get in touch.
Dr. Mehmet, thank you very much being with us and sparing your valuable time and sharing your know-how and knowledge and experience, yours and your institutions and your technology as well.